Well, hello everyone. Welcome to our latest edition of Multi-Modality Imaging Conference. I welcome all of you, and I'll be introducing Dr. Chang, who's one of my friends and mentors. He's gonna discuss nuclear and cardiac CT methodologies of evaluating LV function. We hope that this is an interactive session, and we look forward to this discussion. Dr. Chang.
Thank you. Okay. So first of all, let me make it clear. I'm going to talk about nuclear and CT technology in estimating LV function. But essentially, we're going to be talking mostly about LV ejection fraction. As we say, to know who we are, where we're going to go to, we need to remember where we come from. And you all recognize this gentleman here, the father of modern cardiology. You know that one of his research is actually, he was a nuclear cardiology. So this is one of the first paper with attempts to actually non-invasively image the heart to calculate ejection fraction. And the technique they used was nuclear. So, what kind of nuclear techniques that we use to estimate LV function? So blood pool imaging, there's two approaches. We can have a count-based or volume-based approach. The blood pool imaging, bottom line is, things that we need to know is what we call MAGA, equivalent radionucleic angiography is planar. This is important. We can do tomographic, but usually most of the study was done planar. This is obviously, we do very few right now. But what's more important is about myocardial perfusion imaging, volume-based derived EF. Basically, instead of counting radioisotope activity counts in the LV cavity, we actually image the myocardium. And this is what we do every day when you order a nuclear stress test. The PET or SPECT will give you not only the perfusion information, but also the volume and ejection fraction information. Just real quick, this is what we will see with MAGA. You can see you can have to frame a 16 to 32 cycle, very reasonable radiation exposure, and just very simple. You count the counts at the end of diastole minus end-systole over end-diastole, just give you an ejection fraction. So you can see no geometric assumption. And how we display, usually we play frame by frame to make sure where is the cavity, and then in diastole and systole, and this is a control outside the heart. And the LV time activity curve can be generated, and then also generate parametric Gaussian distribution sinogram to determine the image quality. So this is how we generate ejection fraction. Advantage, again, very well validated in several decades, and there's some source of error, obviously. But matter of fact is we only did 5 studies so far in our laboratory this last year, and I would say it's a lost art, unfortunately. But I'm going to focus mostly on this perfusion-based gated cardiac perfusion derived ejection fraction, because you're going to get this information regardless if you want it or not when you order a nuclear perfusion imaging for perfusion of detection of ischemia and scar. As you can see, basically, it's a fully automated algorithm. After you basically using 3D assessment, you combine the local counts and adjacent neighboring tissue counts. You reconstruct the images, reorient from position data, and you can identify both the epicardial and endocardial surface and myocardium, and you do some mathematical analysis of the radiocount profile, and you can essentially generate volume. Again, it's a gated, depending how many frame, you can do 8 frame or 16 frame. That would determine a little bit different category, different accuracy. So how good is gated SPECT for EF assessment? As you can see, I'm not going to obviously go into all the details, but you can see overall it's very reproducible, meaning in the same patient, we scan them twice in the same day, and it's quite reproducible. And when you compare the different technology techniques, MRI or LV gram or even echo, the correlation is very good. What are the main caveats? What are the main problem? Obviously, the automatic edge detection system could fail when you have a lot of uptake outside the myocardium, or when you have no count in the myocardium. Okay, that without counts in the myocardium, it's hard to generate a border, and that could distort the geometry because, for instance, a huge apical infarct with large aneurysm. And obviously, we all know that is a very low spatial resolution. We're talking about 1.1 to 1.5 centimeter. And that's obviously prone to partial volume effect. And the definition of valve plane for perfusion is obviously approximate. You cannot see valve. Essentially no RV, and low frame cycle, as we mentioned. So EF could be underestimated. And the other thing is there's a lot of different algorithms, okay, and all of them are going to give you a slightly different EF. So that's to be considered when you read the study. Arrhythmia, since most of the non-invasive cardiac study use gated is very prone to arrhythmia. This is a case of arrhythmia, and what you're going to see is in the sinogram, you're going to have all this horizontal stripe. And that's signs of the gating problem of flashing. And you can see this count histogram is completely inadequate for EF assessment. So this is very important when you get an ejection fraction that doesn't make too much sense. You need to go back and look at the raw data for quality control. This is an example of what I said earlier. You have a large extracardiac activity, very hard liver, for instance, or patient who have extensive anterior infarct. You can see there's only lateral wall remain. Having said that, I would say the experience has shown that even in this case, the ejection fraction is quite reasonable clinically. I'm sorry about that. And the other main issue is we all see that and laugh about this because sometimes we get EF 91% with end systolic volume at 1 centimeter, right? 1 millimeter, 1 milliliter, sorry. And this happened because a patient with small heart, because of partial volume effect, the resolution is not good enough. You're going to underestimate the end systolic because that's where the smallest, the heart is smallest. You're going to overestimate the EF, okay? So the reference value, so what's the normal value? You can see, this has been studied. This is a little bit lower than we usually to get from echo or MRI. So, 50% we consider normal, especially for a male, okay? And again, the other thing is image quality. If you have a higher dose, the EF is more reliable. So what do we use this for? We get a number. We not only use the information to calculate EF, it also help us interpret the perfusion study. This is an example. If you incorporate perfusion and function, you're going to have more cases that you can call it normal or abnormal. So you report less borderline cases. So increase your confidence. And we see that every day. If you have a kind of fixed defect and you have a normal motion, and that's most likely the artifact. And this is again a study showing that the reference level, reference range for different EF for different software to give you different ejection fraction. This is a very important concept, especially now we have Pat, Dr. Malahfji published this paper when he was in Boston, and you can see that ejection fraction should increase with vasodilator in the PET study, and if there's no increase, for instance, the term is coined as LVEF reserve. So LVEF is reserve is 0 or negative. Is highly predictive of severe ischemia, and so as predictive of extensive coronary disease. So it's very important that ejection fraction get at rest or stress. And bear in mind that very few center does both EF at rest and post stress. So the fellow who go out there and you set up your lab, I think it's very important also get the ejection fraction at rest and post-stress. Okay, this is, I think I found this paper which is very interesting because everything I talk about is so far is, okay, you compare the ejection fraction between this technique and this technique, but clinically, you know, when you get an EF of 55% and the other technique give you 60%, I mean, I don't think it's a huge clinical differences there. But this paper, this is not a paper where, you know, every patient get all different kind of techniques to calculate EF and look for correlation. This is more a real life in which the EF was assessed and see how we can get some lesson in terms of how this impact how you manage the patient. This is from a stitch study. So Dr. Pelika, she is a known echo lady. So it's Dr. O from Mayo Clinic, but you have a bunch of other imaging techniques leader in this study. So 2,000 patients, they all have coronary disease. EF, most of them are less than 35%. So this in this study, you have almost 60% of patients, over 1,000 patients who got echo and also a nuclear of a CMR. Okay. What's interesting is you would think the patient who had echo has bad quality echo will get referred for other technology. But it's interesting. This multicenter trial that patients who have better quality echo image were most likely to get a second study. And you can see that only 30% of borderline echo quality study got referred for SPECT, and only 15% of borderline study got referred for CMR. That's hard to understand, but that's what we saw. And there's 127 patients got all three imaging modality, which is this cohort makes sense. This is a patient, you know, with a lot of history of revascularization, huge dyskinesia, lower EF, and so on and so forth. So bear in mind, the echo was not done with contrast. So this is very important. This is echo without contrast, but it's important. This is read by a core lab in Mayo Clinic, so supposedly they're the best, one of the best, and and they use biplane methods and also visual analysis and also one single plane Simpson rule to calculate ejection fraction. So when you look at this data, I read about this, and first I was really surprised because you can see that. What do you think? I mean, the echo EF with biplane versus CMR, obviously, you know, there's not it's reasonable correlation, but SPECT EF correlate better with the CMR ejection fraction. And the reason I think is simple, right? I mean, this is all both 3D tomographic type of technology. That's the reason probably they have better correlation. And I think this is more subjected to image quality and also acquisition. So essentially, so SPECT and CMR acquisitions are a little bit more standardized, and echo, depending on the patient window and the center you do it. Okay, so this is another example of, you can see the agreement range between SPECT, for instance, is a little bit smaller than compared to echo versus CMR. And then, but this is the most, I think the most important slides in terms of the agreement, disagreement for calling the ejection fraction more or less at 35%. So using CMR as a gold standard, SPECT correctly or agree, I mean, EF was called either more than 35 or less than 35, agree in 81% of the cases with CMR, and 19% disagree. And echo biplane method, which we consider a gold standard, 25. I was even surprised here is even visually, I mean, that's almost as good as 25. I'm not saying you shouldn't be doing biplane. I think we all the fellows, we should practice and learn how to do it. But I think in expert eyes, let's say Dr. Q or Dr. Zalbi, Dr. Naga, and you know, when they read the study, I mean, the visually, you know, even it doesn't appear to add too much when you do biplane or single plane method. Okay, so essentially, in the real world, clinical settings, there's a lot of variation to determine the ejection fraction, even when this was done in specialized core lab. And they really they couldn't find out why there's so much variation. But the bottom line is that there's no gross overestimation and underestimation. Having said that, this is done in clinical trial, large amount of patients, but for single patient, we still need to be very vigilant. Switch gear to cardiac CT. Okay, so cardiac CT. So the analysis LV volume, mass, and wall motion function. We do it traditionally in by reconstructing, reorientating to a commonly accepted view. Okay, like this apical 4, between 4 and 5, apical 2, and short axis view. This is image that you're going to go through. We'll go actual images. So we reoriented the heart. So we know how to we're used to look at those view. So how do we obtain ejection fraction by doing CT? How do we acquire the images? So we all know about retrospective gating, no dose modulation. This is the grandfather of EF assessment by CT. Typically, we have the scanner, the tube is on during the entire cardiac cycle. So for the heart, this will be acquired between 6 to 8 beats, so around 10 to 12 cardiac cycle. You can then, because the gated study, we can divide the cardiac phases into 10 or 20 or even 20 phases. A study has shown even 20 phases a little bit more accurate compared to a CMR. But bottom line for clinical assessment, 10 phases is good enough. So obviously there's a lot of radiation because tube is on the whole time. This is a helical scan, it's about 6 to 8 cardiac cycle. So you can do dose modulation, meaning you turn the tube, turn higher tube current during systole and doing diastole, turning out. So you look at the coronary. So when it's diastole, there's better signal noise ratio, and this is lower current, so you're going to have more noise. And as you can see that. Before we thought about, okay, sequential, this is sequential scan, prospective gating. Before we saw, okay, we only image one part of one single phase of cardiac cycle, EF cannot be obtained. But if you think about it, if you open the window, we call padding, you can open this as much as you can, or you can open it from end systole here to end diastole, either here, from end of systole to end of diastole, or beginning of systole to the end of systole. So technically, you can also get ejection fraction. This is an example. We do this in TAVR, typical example of our TAVR protocol. We get image from 20 to 80%. And obviously, as I told the fellow, we really cannot talk about ejection fraction here because we do get between 20 to 80% will be around from around beginning of T-wave toward so essentially early to mid systole to mid to late diastole. Okay, so if the EF is normal, it's normal but if EF is not normal, we cannot really report function normal or normal. But just to give you an idea, this is technically feasible. Okay, the other thing that we do is called double flash. This is a case of the patient that we image only take the two look at the LV. You can see one kind of toward the end of diastole, and the other one during mid to late systole. As you can see, this EF is normal, ejection fraction is normal. And the key here for you to understand that a retrospective gating without dose modulation that I showed you earlier, you need most of the cases about 15 to 20 millisievert. This study, for instance, was acquired it was 68. So 68 DLP, which equivalent in this case, 1 millisievert. So in this case, we were able to get 1 millisievert. We can get the coronary information. We can also get the functional information. So this, has potential. Obviously, I don't see the day that we were doing CT for LVEF routine assessment, but it's possible to know those. So how do we calculate the volume and then ejection fraction? So 2D methods, essentially we can do the same thing. CMR, this is Simpson method. It's nothing fancy. But this is most important because this is specific to CT. We call threshold-based 3D segmentation. So essentially, it's automated method rely on difference of the between LV cavity and LV myocardium, and this is completely automated. So when you have a difference between 150 pounds per unit, this technique works very well. You can see you can generate almost like an LV cast. So when you compare 3D methods or threshold-based versus 2D or a lot of user-defined, you can see there's some differences because this one will exclude pop muscle and calculation, and by convention with CT, we include the pop muscle when we do 2D method. So the difference is going to be there, not a huge amount, but that's something you need to bear in mind. And the caveat with 2D is there's a lot of user interaction. If you have image artifacts, step artifacts, and then it's not good enough. 3D, obviously, you require a good homogeneous LVO falsification. I'm going to skip that. And the caveat is similar to nuclear. This is a gated study. And because our temporal resolution is not very good, the best is, with our Siemens scanner is about 65 milliseconds. So the heart rate more than 60, we wouldn't be, we would be underestimating the ejection fraction compared to CMR. And the caveat is when you give beta blocker and the contrast, that could change the hemodynamics and myocardial contractility. So bear in mind, and obviously radiation exposure and iodine. And okay, does it matter which scanner, what type of scanner you use? Well, clinically not. But this last couple of slides, since I'm going to show a little bit of a controversial debate that with the white detector scanner, GE, Toshiba, it's possible right now to do what we call single heartbeat and single threshold CT imaging. Essentially, patient lay there, hold their breath. In one heartbeat, you got the ejection fraction in the size. And this is completely doable routinely. Okay, so let's debate what's the gold standard for LV volume. Okay, I would argue if you have a scanner and your heart rate is 55 or 60, that's been studied. I think the single threshold, single heartbeat CT scan should be personally considered gold standard. Why? Because the spatial resolution is some millimeter. We can do isometric. The voxel is completely the same thickness throughout the resolution throughout the 3 axes, and this is kind of pitfall of MRI that you need to acquire through different threshold, different cardiac heartbeats, partial volume effect due to relatively large slide thickness. And the most important, we discuss this all the time about the mitral valve level. All this I avoided. There's not even an issue for this single heartbeat white detector scanner when you obtain the LV heart. So this is a really old slide, but anyway. So last couple of slides. Now there is also software to look at a strain using CT scan. And this has been around for a while, but I haven't seen much traction about supercomputing analysis. But anyway, the conclusion is the volume and EF assessment by nuclear and CTA are feasible and fairly accurate and provide additional prognostic information. But nowadays, still, I think echo and CMR echo, it should be still the workhorse of LV assessment and gold standard clinically. There's no question because of the radiation, the temporal resolution. MRI is a lot better than CT. But I think about it for research setting. I think this single threshold large detector CTA derived LV size could offer some interesting for research or for research purposes. Okay, thank you. That's all I have.
All right, thank you, Dr. Chang. That was very, very helpful. And while I certainly agree, the CT benefit is not having to deal with that basal slice right under the mitral valve. I'm curious if we have any questions from our local audience or from the group here about your proposal, a single heartbeat, full 3D volume CT acquisition. That's certainly, I mean, many programs are going to be getting CT scanners, so I think it'll be very helpful. And like you said, a very nice research method. Okay, so if no comments.
Yeah, Maan, if I may comment.
I
think in one area where I think it could be useful, again, obviously you've got to balance the temporal resolution and the radiation issues.
Yeah. Absolutely.
But, not so much for just EF assessment, but for volumes. If you have a where you want to really look at rigorous changes in volumes, because EF to some extent normalizes, but volume,
correct, absolutely, yes,
very useful. Yep.
Yeah. And systolic volume, that's probably the most prognostic important. Yeah.
And the other thing is MRI technology is also improving. So let me cover.
You have real 3D MRI currently, right?
Yes, absolutely. Okay.
Takes forever, but that's okay. Will never be a one breast hole.
I will show them some data, but yes, it's still a work in progress. Okay, so I'll be discussing the CMR assessment of LV function in hemodynamics. And I'll give you a few caveats that Dr. Chang alluded to. Let's look at these two hearts. Both of these hearts have the exact same LV ejection fraction, 65% on the left, 65% on the right. But what's the difference? The end diastolic volume of the heart on the left is 164, whereas this one is 259. And if you compete their stroke volumes and systolic volumes, you yield a much higher stroke volume with the heart on the right. And if you notice, this heart has an abnormal mitral valve. You see the severe prolapse in the posterior leaflet, an eccentric jet, and what was calculated to be severe mitral regurgitation with a regurgitant volume of 92 mLs. So these two hearts have the exact same ejection fraction, but one is much larger than the other one. And if you eventually calculate what their forward stroke volume that's getting to the rest of the body, it's not actually that different between the two, but obviously the two hearts are very different. Now let's look at this heart. As you can see, regional abnormalities, you can tell there's been a previous infarction in the LAD territory. LVEF very low, and diastolic volume huge, 434. But this patient only has trivial MR. Notice this, what I like to call a puff of MR. And the stroke volume we calculate independently by CMR from the stroke volume is also 100 cc's. So here you have three very different hearts with somewhat similar stroke volumes despite differences in EF, despite differences in EDV. And you know where I'm getting with this. Ejection fraction doesn't give you the entire picture of what's going on with the heart. If we match all these three patients for heart rate, systemic vascular resistance, and pulmonary vascular resistance, you could theoretically say that their cardiac output at rest may be the same. Now, obviously, if you have the third person start exercising, things will be very different for them. So here's my first message. Ejection fraction doesn't equal your cardiac output. It does not incorporate LV size and is load dependent. So there's been a lot of discussion about this over the past 50 years of cardiology, but it sort of fell out of favor because, like Dr. Quinones alluded to, ejection fraction wins. So here are some parameters to look at contractility. This is how we should evaluate parameters to look at myocardial systolic function. So whatever index you use should be sensitive to changes in inotropy, independent of load, independent of heart size, easy, safe, and improving, obviously. Now, this hasn't really been developed, this parameter. But as we've discussed, the ejection fraction is very easy. You can obtain it easily, you can calculate it easily, and you can track it over time. And we'll discuss the issues with variabilities that Dr. Chang alluded to. And it's strongly supported. Time and time again, low ejection fraction, bad outcome. So if we're going to sort of live and die by ejection fraction, I'm going to discuss how CMR may be one of the most ideal or most effective ways to track ejection fraction and calculate it. We have pretty high spatial resolution, excellent temporal resolution. There's very good signal-to-noise ratio. You can see here how you can delineate the signal within the blood pool as compared to the signal within the compact myocardium. You can create any sort of imaging plane that you want, and there's no need for geometric assumptions when you're doing any sort of calculation. So let me cover a little bit on how we do CMR. So CMR is not, for the purpose of ejection fraction assessment, we create multiple views that mimic the traditional echocardiographic views. And we create these imaging planes first off of an axial shot, and we create these what we call pseudo two-chamber and pseudo four-chamber views. And then we create a slab of slices that cover the entire heart in short axis form. And we end up with cines of the entire heart that we can calculate volumes off of. We use the modified Simpson method. There's been multiple discussions about the papillary muscles. The conclusion of all of the discussions is that you have maintained consistency. So if your lab has been doing, LV ejection fraction and volumes, excluding the pap muscles for the past 10 years, it's something to consider just to continue doing. But I will argue that the pap muscles in multiple studies have been shown to have a significant contribution to LV mass. And there's been studies that show when you include or exclude the papillary muscles from within the mass calculation, your volumes become very different. And that can have huge implications for folks with valvular heart disease and cardiomyopathies and those who underwent transcatheter interventions. So the end result is that it's ideal to include the papillary muscles within the mass calculation. Another thing to keep in mind when we're doing CMR is the heart is moving back and forth within the body, and when we're tracing these end diastolic volumes in this particular slice, as you go back and go to trace an end systole, now a lot of this is within the atrium, but rather not the heart. And here we have the benefit within CMR that we can use a long axis sequence to track all of these at the exact same reference point and resolve the issue of, are you tracing within the left atrium or are you tracing within the myocardium? Now notice I still haven't said anything about contrast use. So if you want to assess someone's LV, whether it's volume, function, you don't need gadolinium. This is a 10-15 minute scan that does not require contrast. Now, we discussed multiple methodologies of assessing EF. How can we sort of assess multiple ways of looking at whatever parameters we're trying to measure? Well, you want to look at how easy it is to do, how affordable it is for your institution and programs to obtain, how available it is, how long it takes, and if there's any risk with doing whatever test. CMR has had sort of the benefit of being very highly reproducible. So whether it's inter-study, inter-observer, or intra-observer within the same person redoing the same measurements, and then against other methods. But you notice, and this is the classic study that looked at comparing heart volumes by MRI versus cast models of human hearts and some other studies, animal hearts. And it showed a very tight correlation, a very small error within the measurements. But like Dr. Chang said, when you have someone with a very low EF, a strongly or a very abnormal heart, all of these numbers are slightly higher for CMR. So it's not unusual to have a variation of 10, sometimes up to 15 milliliters within different studies when the heart is 500 cc's. Now, this has huge implications for trial design. Let's say you're doing a study on a transcatheter device that can reduce MR, and you want to assess how the LV volume changes and how the LV remodels with whatever procedure you're doing. CMR might be one of the best ways to include patients in your study and track them over time, because if the heart is remodeling to a small extent, or if you want to determine a threshold for remodeling of whatever number, CMR is going to be the best way to show a change or the lack of a change, obviously. And this changes the number needed to incorporate into your power analyses for studies. Now, I'll discuss quickly how CMR acquisitions are done. So CMR is dissimilar to CT in the way that it's not obtained as a 3D volume data set necessarily in a matrix that has Hounsfield units, as we know from CT, but rather the data as it is acquired is essentially tabulated in what we call the K-space. And the K-space, think of it as a canvas where you obtain frequency information and you put them in this matrix. So if you collect lines of K-space, you're not exactly collecting the upper portion of the person, and then you're covering the third portion and then the lower portion, but rather each of those lines contribute to the entire image in some way, shape, or form. So as you collect more lines of K-space to create this image, you're improving the resolution and the signal of this image incrementally, and each of those lines contributes to the entire image. So let's say you only collect 4 lines, you're just going to end up with this. You're not going to end up with, a quarter of the image. Now, we've collected one image. How do we create a cine to look at the heart? Well, for CMR, we use what we call segmented imaging. So we very often acquire this cine, this one-time image, over multiple heartbeats. And at each of those heartbeats, here as you collect, there's segments that include these lines of K-space. And as you create these lines of K-space, you tabulate them within the heart cycle, you essentially add them up to result in that cine that we're seeing. So each of those segments does not have one of the frames that you have here. So this is 25 frames. It's not that each of those is one of the 25 frames, but rather each of the cardiac cycles that we use to obtain this image has multiple segments, and in each of those segments there's K-space lines that contribute to the image. And I invite you to come to our CMR conferences to discuss this. So here's our image that results from all of this. The breath hold is about 5 seconds. Spatial resolution is about 1.5 to 2, and you get an excellent frame rate. Sorry about this typo here. This is segmented cine, not real-time cine. This is another way we can image patients. Say you have someone who's not able to hold their breath, not able to do anything other than lie down in the scanner. We can obtain the equivalent of an echo image with what we call this. This is the true real-time cine, so no breath hold. And as you can see, there's a sacrifice with the resolution of the image, but this is pretty excellent too, if you ask my opinion. So the resolution will be slightly lower, the frame rate will be slightly lower, but if you want to look at things like ventricular interactions or changes with breathing with ventricular volumes, then these are very useful. Here's a newer development over the past 10 years or so. This is what's called compressed sensing. And here you can have one breath hold that results in acquisition of all of the short axis slices that I showed you earlier. So this is one slice, but you can obtain all 10 of them within one breath hold. And as you can see here, it's a pretty solid image. You can trace this, you can assess it visually. As you change the acceleration time, the spatial resolution will vary a little bit, and it takes a little bit longer to process on the side of the scanner itself. And recently, this has been shown that it could theoretically reduce CMR scan durations by almost 20 times in daily practice. So we've been doing it. It's been very helpful. A lot of patients, particularly those that we're tracking closely for minor changes or for whatever reason you want to have the best quality, we're still going by the gold standard. But this is a very good option for those who can't hold their breath or have significantly irregular arrhythmias. There's multiple other ways, but I won't discuss that as extensively here. Now let's talk about how these measures differ from other techniques. So we have established normal values for CMR. Let's just look at the upper limits for men as an example. So an end-diastolic volume for men, the upper limit of normal is 203 cc's. Compare that to echo, the upper limit is 150, and that's quite a significant number. What about 3D echo? I will add also, if you index it as 100, and then index this, it's 74. And then if you use your 3D echo, an index number is 86. So it's 74, 86, and 100. And going back to the non-index volumes, that can create a difference as big as 50 cc's between CMRs and echoes, and that obviously has huge implications for whether you call the person normal or abnormal. So just recognize that these numbers mean different things depending on the modality that you use. The other important notes to remember is that our volumes as a person ages will be slightly smaller as you progress to your 60s, 70s, and 80s. The ejection fraction will slightly increase, and there's obviously differences between men and women in terms of normalized volumes. What about ejection fraction? So in this particular study from 2005, if you compare contrast versus non-contrast echocardiography, ejection fraction, I think it's a reasonable conclusion to say that whether it's visual assessment or contrast or non-contrast, and like Dr. Chang was saying, in an expert hand, it's probably reasonable to use any of the above because the prognosis may not necessarily be different between someone who has an ejection fraction of 43% versus 46%. But for what it's worth, there's good correlation between all modalities, at least in this study, which included people with low EF as well. Notice that the ejection fraction on MRI is slightly higher than what we have with contrast echocardiography. And this is fairly established even when you visually assess MRIs, you sometimes look at the MRI and you get the sense, okay, this ejection fraction is somewhere between 35 and 39. But it's not at all unusual to end up with 42, 43. And one of the main reasons for this, in my opinion, and I'd love to hear everyone's thoughts, is when we're all trained to visually estimate EF based on the thickening and wall motion of the myocardium. But with CMR, you're also including that basal slice and that LVOT slice that we're not really assessing. And that can increase your EDV by a slightly greater extent than what it does to your ESV. And I think this notion occurs really in all modalities, but I don't think it's a huge difference in either case. Okay, so this is the seminal study that looked at CMR versus 3D echo. And as you see here, unfortunately, with 3D echo, despite theoretically resolving the issue with foreshortening, there's still underestimation of volumes with 3D echo compared to MRI. So here it's a negative bias of 67 for end-diastolic volume, 41 for end-systolic volume, minimal difference in ejection fraction. The analysis time for this study in terms of the 3D data set was reported to be 5 minutes. Acquisition, where in this study it was acquired over multiple heartbeats, so you don't have any AFib patients or anything like that in this study. It took longer than you'd expect. Obviously now, this was 12 years ago, so things are different. Importantly, the more experience you get with 3D echo, the more closely aligned your measurements will be against whatever it is that's considered the gold standard for that particular issue. So in this study, the bias was actually significantly less for those that were more experienced in managing 3D echo data sets. It was 19% versus 36% for folks who are less experienced. So that's also something to keep in mind. The more and more you do whatever methodology and more experience you get with it, the more your reproducibility will become. And this was the discussion as to why there's this significant of a difference. Here there's a change in literally 1 millimeter of the tracing of this phantom, which is a water balloon. The true size was 150 milliliters. But notice such a significant difference depending on how you're tracing. This may have huge implications for folks, for example, with significant MR, particularly those with functional MR, where you're trying to calculate the regurgitant volume. And here, when you go from 184 to 127, depending on how you trace, you can foresee how this can be challenging, where your regurgitant volume is all over the place. And this was explained for the most part by how echo and CMR differ in tracing the LV. It's difficult to resolve the turbiculations of the heart on 3D echo. In this study, when it was done similarly, if you will, on CMR as it's done on echo, the agreement was much better. Okay, so here's my third message. So volumes, always expect to have an underestimation on echo compared to CMR. Ejection fraction, not so much of a difference, but you may get a slightly higher ejection fraction on CMR compared to a non-contrast echo at least. Okay, so let's talk about assessment of LV function beyond EF, and I'll go a little bit quickly. I'll refer you to this review by Dr. Shamsi. We can assess A velocities, we can assess E velocities. There's a study that derived a CMR E to E prime ratio and had very good predictability of filling pressures. However, this was difficult because it's not necessarily ready because it doesn't have all the caveats that we have for diastolic function assessment. TR velocity is challenging. For HFpEF research and HFpEF, if you will, early prevention or early detection, multiple CMR methods have proven to be useful, including things like ECV, looking at strain parameters, whether it's the LV or LA. There's already established criteria for filling rates, the AV plane descent and the sphericity index, not necessarily used clinically. This is quite supported by multiple prognostic studies. For example, looking at the mitral annular descent or excursion on CMR had shown to be quite a prognostic value in those who this was a multicenter that looked at folks who were referred for a clinical indication for CMR and had a history of hypertension. But it was also shown to be useful even in those with normal ejection fraction, no history of MI, so something to look into. CMR tagging has sort of fallen out of favor. You can track each of the myocardial segments against time, and in this review and other studies, it was, in the past used to track how things change in those with myocardial disease. You can evaluate wall motion reportedly better than just visual estimation of wall motion akinesis, dyskinesis, and whatnot. Feature tracking now on CMR has become more of the standard way of looking at strain parameters. This was a relatively small study that looked at those with proven restrictive cardiomyopathy and proven constrictive pericarditis. And CMR-based methods of assessing strain were able to separate out those who have constriction versus restriction. Keep in mind, now we have an unobstructed complete view of the pericardium on CMR, and that creates a lot of benefit in looking at those with possible constriction. Feature tracking global longitudinal strain, also proven to be prognostically useful despite LV ejection fraction, and more importantly, despite LGE, even in those who have, traditionally LGE or delayed enhancement on CMR has been traditionally considered to be one of the strongest parameters of assessing prognosis, but longitudinal strain has been useful and can be done as well. So these parameters can be assessed on CMR, however, not routinely reported, at least in the institutions that I'm aware of. This really has to do, I would say, with how long the exam takes. Let's cover a little bit about what's going on with the future of MRI. So everyone's talking about AI and machine learning. So this is a large study from the UK Biobank that looked at an AI methodology of assessing volumes, whether it's LV, RV, and LA and RA, and had very good agreement against experienced observers. And you can see the numbers here are very minor differences between the machine and the man or the observer. But I would say, having done some of them, at least on the software that's available to us, it really comes down to having very good image quality, and very often it's very good in normal hearts, but not necessarily in abnormal hearts. So let's look at this study. Here's a myocarditis case. You can see the algorithm did very well, traced the LV very nicely, traced the RV very nicely. This is a person with a TAVR, and here you can see it did okay. The RV, I think it got lost here, if you notice at this segment, and had no idea where the RV is. Let's look at HCM. This is end systole in HCM, and the end systolic volume is definitely not this. It's more like this tiny little bit of thing here. So completely missed the volumes in this case. Dilated cardiomyopathy did okay, but here there was a continuation of the papillary muscle or potentially a thrombus, but acceptable here since there's no major changes in the function of in the parameters of the heart. Tetralogy of Fallot, I mean, here you just have to trace it yourself. The RV was completely missed by the algorithm and didn't really do very well at all. So the variation in this study was better for the LV, not so good for the RV. More work to be done. I imagine that the more improvements there are in exam speeds, let's say your lab is doing 10, 15 studies a day, it's reasonable to trace manually. But let's say your exam duration now goes down to 15 minutes, 30 minutes for some cases. It's going to be hard to trace all of these cases manually. It's going to add a lot of time. So more to come, and I think I will end here. Keep these indications in mind. So CMR is one of the best ways to look at someone with a new diagnosis of heart failure or suspected heart failure, new LV function, and as you all know, following patients, for example, who are getting cardiotoxic agents and those with VT and other serious arrhythmias. All right, let's see if there's any questions.
Hey, Maan, this is Eric.
Hey.
Hey, so I saw that you showed that there's real-time single breath hold sequences. Any advances on the 3D CMR SNAs?
I saw a bit about that. I didn't really include it here. I don't know of any commercial software that's doing it. Unfortunately, a lot of these studies are done on software developed in-house or some proprietary software that's not available to us. So I would say before it's something that's available commercially, it's hard to say. I don't know. It will be very nice.
And the second question is for post-processing. Very nice presentation on tracings and going through the issues related to that versus echo. Has there been any advances on trying to incorporate like accommodating 3D tracings on the long axis, like the mitral borders, to improve accuracy?
Not that I'm aware of. You're saying 3D volumes to try to exclude the areas above the valve plane? Let me make sure I got that right.
Yeah, the mitral valve leaflet borders, because that often presents an issue with trying to get the volumes correct around the bases.
Yeah, no, I haven't seen any. I think a lot of these intricate details, and as you all know, folks, for example, with mitral valve prolapse, folks with pseudoaneurysm, a lot of these complicated patients, it's going to be a lot of manual adjustment. But I'm not aware of anything automated to try to detect the valve plane. No.
Thank you, Maan.
Yep. All right. Well, thank you all. See you next Tuesday.